Can you maybe advance the slide? Okay, perfect. So today I'm going to provide an overview of the most common side effects in multiple myeloma. The ones that I'll focus on today is peripheral neuropathy, constipation and diarrhea, rash, thrombosis, and neutropenia, thrombocytopenia, anemia, and fatigue. And I'm going to teach you guys some strategies on how to manage these side effects. All right. Sorry, some technical difficulties here. So this is just a picture to show you guys what the neuropathy looks like. So on the left-hand side, this is a picture of what the normal nervous system looks like. And then on the right-hand side, this is a picture of what the nervous system looks like once you start getting some neuropathy. So you can see the nerves on the hands are affected first, and same with the feet moving up into the calves. And then this is that classic stocking glove syndrome. So typically what patients feel is the blue is representing cold or numbness. So you feel numbness and cold in your toes or in your fingertips. And then the sort of heat or burning sensation moving up into the legs and into the arms. So some presenting signs and symptoms are, of course, that numbness, but also can be some weakness. Usually that would be mild, but you could feel weak in your legs. Some autonomic symptoms, this would include, could be incontinence with your bladder or with your bowels. Could be some balance issues. And then, of course, neuropathic pain. So nerve pain is basically described as sort of a shooting or that burning sensation, kind of like this guy walking on the coals here. Or it can also feel cold, numbness, cold. Kind of like for those of you from more eastern parts of Canada, if you've ever frozen your feet in the middle of the winter, you know that feeling when they're sort of really, really cold and they're frozen and numb, but then when they start to thaw and you feel sort of that pain sensation, that's kind of what neuropathic pain can feel like. So what causes it? Well, pretty much well, actually, nowadays it's a little bit more rare. So BORTEZOMIB in particular used to be one of the culprits, but this has actually decreased a lot since we switched to subcutaneous administration of the drug. And also we've switched to giving it once weekly instead of twice weekly. So this has actually dropped the incidence by at least half, between 50 and 70% it's dropped. So this is good. Thalidomide is the one that used to cause a lot of issues, but again thalidomide, we've actually decreased the dose. We used to give it in quite high doses, 400 milligrams and more, but now we usually give about 150 milligrams if we're going to use that drug. And then in pomalidomide and lenalidomide, this is also called Pomalyst or Revlimid. It's much, much more rare to see peripheral neuropathy with those drugs. Another cause of peripheral neuropathy is also spinal cord compression. So many of you, you may have lesions in your spine, and if those fracture, then this can compress on the spinal cord. So that can also cause neuropathy issues. And then other comorbidities, so like diabetes. So often people with diabetes will have a little bit of numbness, neuropathy in their hands and fingers. So of course, if you have diabetes plus myeloma and on some of these drugs, that can just make it all worse. Do you want to advance the slide for me, Gabriel? There we go. So symptom management. So for pretty much all the drugs, bortezomib, thalidomide, pomalidomide, lenalidomide, basically we have to hold drug until the nerve pain resolves, and then we have to dose reduce once it does resolve. As I mentioned before with giving Velcade, just giving it once weekly instead of twice weekly, and then also because we've now switched to giving it sub-Q, it's a lot better tolerated. But of course we do have to hold drug I do want to tell you, if you do experience some neuropathy symptoms while you're on any of these drugs, please make sure that you report it to your physician right away. This isn't one of those side effects that you should, hold back or try to, deal with it on your own. This one we actually really need to know about so that we can hold right away and do something about, because it will get worse over time if we don't know about it and if we don't do something. Same with spinal cord compression. This is actually a medical emergency. So, if you have a lot of pain in your back, especially if it's sudden pain in your back, and then also numbness, neuropathy following, this you should go see your doctor right away. And actually, if you can't get into your doctor, you should probably go to emergency to have an X-ray or a CT scan to make sure that your spinal cord is okay. And then, of course, if you do have diabetes, make sure that you're monitoring your blood sugar regularly, and especially if you're taking steroids like dexamethasone or prednisone, because those can also affect your blood sugars. Okay, so some medications. There are some medications that we can use in peripheral neuropathy, but it's just symptomatic treatment. So really all it's doing is covering up the neuropathy. So it doesn't actually treat the neuropathy, it treats the symptom of the neuropathy. There are 3 classes of drugs that are typically used. These are the anti-epileptics, antidepressants, and analgesics. So for the anti-epileptics, you may have heard of gabapentin or Lyrica. Both have the same mechanism of action. One's not better than the other. The gabapentin is taken 4 times a day. Lyrica is only taken twice a day. So sometimes patients just choose one over the other because of the convenience of it. Also, Lyrica is much more expensive than gabapentin, so sometimes price makes the difference. And sometimes, switching from one molecule to another, it just tends to work better. Everybody's body is different, so some people just think that one over the other works better. So some common side effects, though, of these drugs is drowsiness, dizziness, nausea, vomiting, constipation, some edema. This is swelling in the hands or the feet and lower extremities. Just a note, you can't just stop these drugs abruptly, or you will have some withdrawal symptoms, so they need to be tapered. And your doctor can talk to you about how you taper it, but it's very slow taper over a few weeks. And then just a note that patients over 65 years old are a little bit more susceptible to any side effects of these drugs. Other tricyclic antidepressants, it may seem weird that why would we use these to treat neuropathy? Well, it's kind of all because of the nerve stuff going on. And it's to do with some of the nerve centers in your brain. So amitriptyline is the one that we typically use here in British Columbia, but there's these other ones, nortriptyline, imipramine, desipramine, doxepine. The doses range from 10 to 150. We typically give around 25 milligrams, and we tell patients to take it at nighttime because this one can make you drowsy. So we typically say 25 milligrams at night. Side effects of this one, again, are drowsiness, like I said, which is why you should take it at night. Dry mouth, urinary retention, meaning that you won't pee as frequently, confusion, nausea, vomiting, constipation, and again, over 65 years old are at higher risk for side effects, may cause cardiac toxicity. This one is best used if you already know that you have a history of depression. So then if you have a history of depression and you have some neuropathic pain, this tends to be the one that we try. Topical analgesics, so there's been some studies on these. We found that they don't really work very effectively, so we don't use them for this indication. The cannabinoids, these are things like navalone, also marijuana. So there are pill forms of the cannabinoids. The one that we use here in BC mostly is navalone. They're also approved for antiemetics, so if you have nausea, they're also good for that. Sativex is one that you can also get for cancer pain, but these need to be prescribed by usually pain care specialists. So your regular oncologist may or may not feel comfortable prescribing this one. So if not, though, they can consult some of the pain care specialist people. So then we move into the analgesics. These are the opioids, so morphine, fentanyl, hydromorphone. These are less effective than those anti-epileptics that I talked about first, the gabapentin and the Lyrica. And of course, these ones have quite a lot of side effects. Tramadol, this is another interesting option. Tramadol in particular, it mixes tramadol with acetaminophen, so there's a little bit of opioid in tramadol, so mixing it with acetaminophen. This one actually tends to work really well. It's prescribed a lot for people with back pain, so other kinds of soft tissue damage, things like that, herniated discs, they use Tramadol for. And some nutritional supplements. So you may have heard about some vitamins and things that you can take. I just want to really point out that prevention of the neuropathy is key. So really we want to make sure that you don't end up with nerve pain. So holding drug stoppages and then dose reductions are much more preferred. And that's always our first go-to. You can take these as a preventative measure if you want. Most physicians will tell you that multi-B complex is probably all you need. If you take all of these different things, it starts to add up. It gets pretty expensive. If you happen to have cramping along with your neuropathy, you can have your magnesium and potassium levels checked, and then those can easily, you can take some magnesium and potassium, or you can check out what foods are high in magnesium and potassium, things like bananas, potatoes, and that'll help increase those levels to stop the cramping. The other thing is tonic water. Tonic water contains quinine. Now for some patients, so quinine is actually the thing that will calm the cramps. Some patients find though that the tonic water is just not enough, or they just don't like the taste. You can also get quinine tablets from your doctor. So you just have to ask. And then there's cocoa butter. I'm not sure that the cocoa butter actually does anything, but a massage always feels good. So you can try that. And then essential oils, things with menthol, eucalyptus, or spearmint. I had a patient who had some neuropathy problems, and she was rubbing her feet with Vicks Vapor Rub, and she swore by it. She thought it helped them feel better. So it's not going to hurt you. You can try that. Also, try keeping your feet elevated during the day. Okay, so we'll move on to constipation. So drugs that can cause constipation, basically they all can. So bortezomib, thalidomide, pomalidomide, lenalidomide. The other thing is, you know, if you're having other side effects, especially, so sedentary lifestyle, but, you know, sometimes it's, you know, it's because you're having so many side effects, so you're just kind of, you know, only able to sit on the couch and you're not able to do a whole lot. So these things are only going to make constipation worse. And then if you're not drinking enough, dehydration is also a cause. So what can you do? Exercise. Gotta walk. Try to get up and walk. Even if all you can do is get outside, walk around your block and come back, any little bit, it's going to help. There was a study that showed that actually just to maintain regular health, this isn't for training purposes or anything, but all of us really need to get 150 minutes of activity per week. And that exercise needs to include both cardio and resistance training. And also regular exercise is going to help with pretty much all your symptoms. You're going to find during this presentation, I'm going to put exercise in there quite a bit. So just a little piece of information. This study that I'm telling you about, where that concluded that we need at least 150 minutes of activity a week, also found that doing 15 to 20 minutes of high intensity training equals 1 hour on the treadmill or elliptical. So you don't have to, you know, be working out for long periods of time in order to maintain your health. And 15 to 20 minutes, so high intensity, really this is getting your heart rate up. So whatever that means for you. So everybody's sort of cardiac zone is different. So I would recommend that you see a physio or a kinesiologist. They can help you figure out what kind of exercises you can and should be doing and how much you can be doing. The other thing is for that resistance training, yoga, Pilates, and Tai Chi were found to be just as effective as weight training. So you don't have to go to the gym and be lifting weights and things like that. Of course, if you're able to, you can. But also if you feel to do more gentle types of resistance training, yoga and Pilates and Tai Chi also work very, very well. For this, I would definitely recommend, especially if you have any known lesions because of your myeloma, see if you can get just the most recent skeletal survey report from your physician, and make sure you bring that with you when you go see the physio. That way they can tailor the exercise for you. So the other thing that you can do is your diet. So basically high fiber foods. So really, we're talking about fruits and vegetables. These are the best things. So the more fruits and vegetables you can put in your diet, the more it's going to help with constipation. And then, as I mentioned before, plenty of fluids, lots and lots if you can. So 8-ounce glasses of water a day. I tell most of my patients, if they have a nice big, 1 liter or 2 liter bottle at home, fill it up in the morning and try and drink all of it throughout the day. Medications, there are these medications that you can take, but of course, you're already on medications, and I know many patients don't want to take more medications, but if you do have severe constipation, so really you should be having a bowel movement every day, at least once a day minimum, and then maybe for some of you it's more regular to have it every other day. If you're only having a bowel movement every other day and you're also sedentary and taking, let's say, morphine or something else for pain, you may need CLOTS or Senecot or lactulose or milk of magnesia to help you out. Really, you want to get your bowels going every day. You want to make sure that you're getting rid of everything. And these, so CLOTS and Senecot, those are available over the counter, but you'll need a prescription for lactulose and milk of magnesia. So diarrhea, again, pretty much bortezomib, lenalidomide, dexamethasone, chemotherapy, and of course viruses, parasites. These things can cause diarrhea. I did actually have a patient who we did not discover that he had a parasite until he was on lenalidomide for about 5 months. We thought that it was just the Revlimid doing it to him, but then lo and behold, we actually found he had a parasite. So do make sure to get that checked out, especially if you've been traveling. What you can do about it, drink plenty of fluids. Remember to take some electrolytes with it. Electrolytes are basically salts, so things like Gatorade and Pedialyte. If it tastes too sweet, you can just water it down a little bit. But you do need the salts as well to help your body actually retain it, because often what happens, you drink the water and it just goes straight out. But if you put some salt in there, your body's actually going to absorb it more. And then the typical brat diet, this is bananas, rice, applesauce, and toast. You can also try some fiber or natural bacterial flora supplements, so things like yogurt, some acidophilus, and again, medications that you can take for severe diarrhea. You can take Imodium, 2 milligrams. Try 1, and then you can go up to 8 milligrams per day. They're 2 milligram tablets, so 1 tablet is 2 milligrams. I did have a patient who was he happened to be having a lot of pain just from his myeloma, but also was having a lot of diarrhea, so we actually ended up putting him on codeine, 15 to 30 milligrams 3 times a day, and that seemed to help calm it down. But now we know that Revlimid in particular can cause this BAM syndrome. That's a bile acid malabsorption syndrome. So in order to figure out if that's what's going on, your doctor can order a blood test, but then you'll need to decrease the fat in your diet because that's known to make this worse. The other thing is you can get a prescription for cholestyramine. It's also called Questran, and we find that this is very effective. So this is with Revlimid that they found this. So just make sure that you're letting your doctor know that you're having diarrhea. Don't just take these side effects as if they're normal. They're part of the treatment, unfortunately, for some of you, but do make sure that you tell your doctor or your nurse so that they can actually get you some of these things and get it prescribed for you. So moving on to rashes. So actually all of the drugs pretty much can cause a rash, and also shingles infection can cause a rash. So patients with myeloma are at higher risk for shingles reactivation. This is basically chickenpox reactivation, is what it is. So if you had chickenpox as a kid, then you're at risk for a shingles infection. And it's just because your immune system's not functioning properly, and then we give you these drugs which are going to lower your immune system further, so then that can it's kind of an opportunistic thing. It can reactivate. So this is typical of the shingles rash. This is what it looks like. Tends to be sort of a maculopapular. So this is basically a raised red rash. It tends to be very painful. And as you can see in this picture, it's actually sort of in a line. So this one tends to follow your nerve roots, and your nerves, basically if you're looking at your back, your spinal cord, your nerves tend to go out kind of like I don't know, like an arc kind of around and then around into your ribs. So that's why it typically follows this pattern. It can occur at any time, but the incidence with bortezomib treatment is higher. And this is why we will often put you, well, we always put you on Valtrex, but I'll talk about that in a second. So the typical bortezomib rash. So this is the rash that you can get with bortezomib. As you can see, it also can be a red raised rash. This one tends to be itchy. So not necessarily painful, but itchy. And you can get it, it usually appears on the back or on the chest for the first, when it first starts. And it also can come and go throughout treatment. So sometimes, as long as it's just on a small part of your body, so make sure that your doctor assesses, but if it's just on, let's say you just have a few spots on your chest, we may just continue with your treatment. But if, so this guy here who's got it all over his back like this we would typically hold, we would probably dose reduce. But it doesn't mean we have to stop. That's my point. We don't necessarily have to stop, but we should hold and just wait and see if it resolves. Now the bortezomib site injection reaction. So this is different. This is where we're actually, it's a reaction that's happening where we're giving you the injection. So you're probably getting your injections either in your abdomen, maybe rarely in your thighs, and then maybe in the back of the arm. You could see a red or a raised bump around the site, maybe a hard lump underneath. So make sure that you're rotating sites. So don't ever take your shot in the same spot within the same cycle. And the nurses will probably be charting where they've given it. But you know, you can help them out if they, you know, people are human, they can make mistakes sometimes. So just make sure that you're rotating sites. So if you get it in your left side of your abdomen this week, make sure next week move to the right side. And as long as you've got at least an inch in between your sites, that's fine. So you could still put it, let's say, in the lower abdomen and then next time in your upper abdomen. So just make sure you've got at least an inch in between. And make sure when you're getting your dose, on your dosing day, wear loose-fitting clothing. If you have anything, especially if you're getting your injections in your waist, if you have a waistband on, this can actually create heat and friction around that injection site, which can lead to more skin reactions. Right now it's summer, so if you can, you know, wear a nice loose, for those ladies, wear a nice loose dress if you want. That's probably the best thing. But otherwise, just make sure whatever you've got around your waist is nice and loose. And then don't touch it. So just leave it alone. If you can, shower before you go to get your dose, not after. Because again, that heat, it can increase a skin reaction. And ensure that that shower spray isn't hitting directly at your injection site, because that also can irritate it. And make sure you report all injection reactions to your healthcare team, and don't use any creams or gels on that site unless it's prescribed to you by your healthcare team, either your physician or nurse practitioner. Okay, so this is what the rash looks like for lenalidomide, pomalidomide, and thalidomide. Now this one is actually a really severe one. This one tends to be very flat. Sometimes you don't even see circles like this. It can just be all red, and it tends to move from the legs up. I don't know why it moves like that, but this is what it does. It's usually itchy as well. So make sure again that you tell us about it. So this is prophylaxis for that shingles that I mentioned earlier. You can take Valtrex, also called valacyclovir. This is that blue pill that you're taking, and you take it once a day. Some patients will take acyclovir instead. Acyclovir is just a little bit cheaper. You can try, if you have very itchy or dry skin associated with these rashes, you can use some shea butter or cocoa butter or other moisturizer. What I would recommend though is use a moisturizer that you're used to. Don't try something new while you've got a rash, because then if you happen to have a reaction to that new moisturizer, now we don't know if that's making your rash worse or if it's, you know, something with the drug. So just use your tried, tested, and true, what you know works for you. Dose reduce, of course, we have to dose reduce the medication if more than 50% of your body surface area is affected. So, you know, if you've got your back and your chest is being affected, for sure we're going to have to dose reduce. Some doctors, even if, like that picture that I showed you where the whole back was covered, we may actually dose reduce even for that, even though that's technically only maybe 25% of your body's surface area, we might. Itchiness, you can take Benadryl, that one's over the counter, but the Atarax you would actually need a prescription for. Side effects of those drugs include drowsiness, dry mouth, and again, the elderly can be more susceptible to the side effects. You can also get, for severe rash, hydrocortisone cream, so your physician can prescribe you this. There are some over-the-counter formulations available. You just have to ask your pharmacist. So thrombosis, this is known as blood clots. So you can get blood clots in your legs. Those are called DVT, or deep vein thrombosis. You can also get blood clots in your lungs. Those are called pulmonary embolus. The incidence, and VTE is a venous thromboembolism. Sorry, this is healthcare practitioner speak, but basically it's blood clots. So it varies, but the things that we know that can cause it and increase your risk is if you have a central line. So probably most of you don't get central lines unless if it's during your transplant. You may get a central line put in if you're getting some kind of IV therapy at least weekly, then we might give you a central line, but typically for myeloma patients nowadays, you would only get a central line during your transplant. And a central line is basically, there's two different types. You can have one that's peripherally inserted, so it goes into your arm. It's called it's the space that's just on the opposite side of your elbow, the antecubital fossa. It can go there or even a little bit higher, but this is a line that gets inserted there and then it dumps into your heart. The other kind of a central line is a Hickman line, and it goes right into your chest and again dumps into your heart. Or portacath. The portacath is that device that sits underneath your skin and we access it that way, and that's another form of a central line. And then, so the other things that we know can increase the risk of blood clots is chemotherapy, so high-dose chemotherapy, hormonal therapy, so if you're also taking any kind of birth control pill or even Premarin, things like that. Surgery, if you've had surgery, we know this can increase the chance of blood clots. And then these erythropoiesis stimulating agents, so things like Darbo, Poetin, or Eprex. So the background incidence of, so the chances of getting a blood clot in myeloma, it's about 5 to 10%. But if you're on any of these medications, it can increase your risk. That's all this is describing. So we know that your risk is somewhere between, could be as low as 3% and as high as, if you were on thalidomide and some kind of a chemo, anthracycline is like a melphalan or a cyclophosphamide, it could be as high as 58%. So we definitely watch you guys for this. So some signs and symptoms to watch out for: pain or swelling in any of your limbs, so your arms, your legs, and it's typically one-sided. It's rare to have a clot in both legs or both arms at the same time, but I have seen it happen once in my entire career. So 15 years I've seen it once, but most of the time it's going to present in one side. So for those of you who have swelling from fluid, that's going to look different. If you've got swelling from fluid, typically you can push your finger into it and you're going to see an indent. But if you have a blood clot, you're not going to see that. You could also have pain. Usually it's accompanied with pain, especially if it's in the calf or if it's in your chest. And if it's in your chest, it's going to be worse when you take a breath in. Also, you would probably be experiencing shortness of breath. So if you have any of these side effects, this is a medical emergency. Don't wait to get an appointment with your physician. Go straight to your local emergency room and have it checked out. They will probably have to do ultrasound or x-ray or x-ray. So we usually prescribe baby aspirin as prevention. If you're on lenalidomide, pomalidomide, and thalidomide, typically we don't give you baby aspirin otherwise, because if you're getting, let's say, your high-dose chemo before transplant, your platelets are going to be really, really low. You're actually already at risk to bleed, so we're not going to put you on baby aspirin at that time. And then bortezomib, actually, we didn't see any increased risk of blood clots with bortezomib. So if you're on bortezomib, that's Velcade. If you're getting that, you're probably not on a baby aspirin, unless if you have other reasons to be on it. If you've had a blood clot in the past, or if you've had any cardiac events in the past, then you'll have to just continue taking it. But otherwise, typically, we would only put you on it for lenalidomide, pomalidomide, thalidomide. Some patients also will be prescribed a low molecular weight heparin. This is if you've already had a blood clot in the past. We're going to put you on this instead because it's more effective. So the one that we use typically is Fragment, also called dalteparin, and this one is injections. This one works very well. We don't worry so much about your blood tests. So the PTT and INR, this is your clotting times. With this drug, we don't have to worry too much about it. So this one is the one that we typically use for cancer patients because you already have a risk of bleeding if your platelets are low. We can also use warfarin. This is also called Coumadin. These are tablets. But if you take this one, then we do have to check your blood work because this one can increase your bleeding time. So that's kind of the trade-off. And warfarin's activity is affected by chemo, so we often have to increase it or decrease it. So we have to monitor you a little more frequently. So this is why myeloma patients are not the best candidate for warfarin. If you have low platelet, so this is another common side effect of all of those drugs, pretty much all of them. So we typically do blood work at least once a week or every 2 weeks. So your platelets, those are the part of your blood that helps your blood to clot. And neutrophils, those are your infection fighters. So these are part of your white blood cell count. So if these are low, really, really low, so typically for platelets, we don't transfuse unless if you're below 10, so 10 or less. But sometimes if you're also symptomatic, like if you're already having nosebleeds and really bad bruising, we may prescribe platelets if you're below 20. But 10 is usually our threshold. And then Neupogen, we can give Neupogen to help increase your neutrophil levels. And again, we typically don't give that drug. That's an injection, and it's quite expensive. So we typically don't give that one unless if your neutrophils drop below 0.5. That's the threshold we usually use. And it differs. There might be different reasons why we might let it go lower or make sure that it stays higher. If we try all these things and your counts still remain low, your doctor may need to repeat a bone marrow biopsy just to make sure that you don't have some myeloma coming back. And then you would have to change treatments if that was the case. So they may actually order a bone marrow biopsy. So symptom management for this, there's not a whole lot that you can do for your platelets and neutrophils, so make sure you do report all of any infections that you have to your provider, to your nurse practitioner or physician, and your nursing team. Make sure you're washing your hands frequently. That's always, washing your hands is your best way to avoid infections. And avoid crowds if your neutrophils are less than 1. Watch for and report any signs of bleeding and bruising to your provider. One thing that we know, so vitamin K helps to clot your blood. You can actually have your levels checked to make sure your vitamin K isn't too low. The other thing you can do is try eating cantaloupe and kiwi. This will help increase, those are really high in vitamin K. You may still need supplement though if your vitamin K is too low. Okay, anemia and fatigue. So I like this, this is one of the scales that I like the most because often when I ask my patient how they're feeling and they tell me they feel fatigued, I ask them, well, how fatigued are you? They say, oh, it's not too bad, it's mild. So we think, okay, well then you're in this, 1, 2, or 3 sort of a range. But then when I show them this tool, they actually they point to the extreme fatigue, which is like 7, 8, or 9 out of a scale of 10. So it just helps sometimes to put a visual to the rating scale. And that's a little red blood cell, if you were wondering. So what, up to 100% of cancer patients are fatigued. It is one of the most common symptoms that they tell us about. And 30 to 75% of cancer survivors continue to report fatigue symptoms months to years after their treatment ends. Now this study, this was for a solid tumor type cancers, but I think it also rings true for multiple myeloma. So how we define it, basically this is unrelenting fatigue, a sense of tiredness, unrelieved by sleep. So even though you might nap, you get a good night's sleep, you wake up, you still feel tired. The thing that's causing it is both the myeloma and the treatments we use for the myeloma. So we also know that patients are underreporting their fatigue, and the reasons for that are because you're afraid we're going to either hold or stop your treatment. Sometimes you just think, oh, this is just a normal part of the treatment, so why do I have to tell my physician? It's also slow and gradual, so it's often not until you're feeling better that you realize how fatigued you actually were. And then again, sometimes there's just that disconnect between, reporting how bad it is. So you may tell us that it's mild, but actually it's moderate to severe. You might think that your physician has better things to worry about than your fatigue. And most patients are unaware that there's actually things we can do about it. So it's a normal side effect. It's caused by the myelosuppressive effects of chemo. So basically, the different drugs we give you can cause your red blood cells to decrease in your bloodstream. So the top picture, that's how many blood cells you're supposed to have in your blood vessels. And if you have anemia or low red blood cells, that second picture is what that looks like. And it's caused again by an inadequate red blood cell production. So this can be because of the drugs we're giving you, or it can be because you still have some myeloma in your bone marrow. Your red blood cells are made in your bone marrow. So if you have too many myeloma cells there, they crowd out your red blood cells, so then you're not going to make enough. Some other things, cytokine inhibition of erythropoiesis. So, and then low serum erythropoietin levels. This is due to kidney impairment. So if you have kidney issues, you may also have low erythropoietin, which will affect causing anemia. And that's it's also a part of the myeloma. So some treatments that we can do, we can give blood transfusions. We can give erythropoietins. We typically don't give these though in multiple myeloma. Some centers they do, but we typically don't here in BC. These drugs, Eprex and Aranesp, they're very expensive. And as I showed you before, they also increase your chance of blood clots. So some patients will take it if we're really, fairly certain that it doesn't, or that they're not going to be at high risk. But for anyone who's at high risk for blood clots, we wouldn't do this. I'm going to talk to you about some nutritional things. The other thing is just some patient and family education, just knowing that these are the things that you can do. Energy conservation, so making sure take a nap if you need it. Sleep and rest is very important while you're on treatment. Your body's working really hard to try to fight this disease. It's working really hard to try to get rid of all these drugs that are, trying to pee out all of that myeloma basically. So you really need to rest. Some other things you can do, make sure if you're really feeling stressed out, that you're managing your stress, get some psychosocial support. We're now realizing there's been lots of studies on practicing mindfulness and meditation. This is sort of the new thing that we're realizing it's actually beneficial for all of us. We all have stress, but of course your stress can be increased. So these tools actually are really beneficial for anybody with cancer, or anybody really for all the things that you go through in life. There's always something, some tragedy, something that we have to deal with. A life coach, I always wondered, what is a life coach? Well, a life coach is somebody who specializes in mindfulness. And mindfulness isn't necessarily, you know, sitting there with your eyes closed for an hour. Mindfulness can be done even with your eyes open. It can be 5 or 10 minutes a day. It's really about just focusing, maintaining that focus internally, making sure that you are sort of grounding yourself into the present. And also it helps you to just kind of shut off everything else, shut off your mind, and just really focus on how you're feeling. Because sometimes you'll go through days, weeks, and you don't even realize how you're feeling until you actually sit there and stop, and you know, everything stops around you. Then you can actually realize, geez, I feel really tired, or I feel really whatever, nauseous, whatever. So that's why it's so important, and a life coach can really help. Life coaches are expensive though, so for those patients who can't afford it, there are other places that you can go, and that's for free. So I'm going to tell you about those in a second. The other thing is exercise. As I said before, you got to walk. This is true for all of us. In order to feel energetic, you have to put out energy. That's just the way it seems to go. So walking is one thing that's, you know, probably one of the easier things to do, as opposed to actually having to, you know, go to a gym or do something like this. But as I mentioned before, all of us really need to do a mix of cardio and resistance training. And don't be afraid to keep doing your normal activities. You can see a physio or a kinesiologist, and we actually have in BC, we have something called Inspire Health, where you can actually see physio and kinesiology for free. All you need is your MSP number and they will see you. So that's Inspire Health, and it's also at the end of my presentation. They also practice the meditation and mindfulness. They have free classes there. And I know across Canada, they also offer things like this. I think in Ontario, there's something called WellCan, and there's other supports like this that are available all across Canada. So just do some Googling and you'll find it. And of course, social support. If you're feeling fatigued, you're probably staying inside a lot because you don't feel enough energy to go outside and go see your friends. Even just this disease itself, even if you were feeling okay, maybe you're, you know, feeling stressed out and depressed about, maybe your doctor just told you that you've relapsed, so, you know, you kind of go into that cocooning phase while you're, you know, sort of dealing with that. So a lot of patients do tend to isolate themselves. So biggest thing to do, reach out to Myeloma Canada. We have excellent support groups all across Canada. Also, don't be afraid to reach out to your friends and your family and tell them that you're not feeling well. You know, typically I don't know if this is a Canadian thing or just a human thing, but you know, you tend to put a smile on your face and pretend everything's okay. You don't have to pretend everything's okay if it's not. And also making sure that family realizes that it's okay to not feel okay. So some of the nutritional things that you can do, so we know that some patients with cancer, with myeloma especially, can experience changes in nutrition, decreased appetite, or even taste changes. This happens because of the different treatments that we're giving you. So really, iron, vitamin B12, and folic acid are really important. They tend to be the things that are low in myeloma patients. So make sure you're eating a well-balanced diet when you can. Nausea aside, that we'll talk about in a second, but when you're feeling well, that's the time. Make sure that you're eating well. And basically, what is eating well? There's a lot of stuff you're going to find on the internet these days about what should I be eating, what shouldn't I be eating. The gist of it is lots of fruits and vegetables. It's not really rocket science. We know we should be eating lots of fruits and vegetables. Potatoes are actually really good for you. They've got a lot of potassium. I know they've kind of been demonized because they're a carb, but potatoes have a lot of good minerals and electrolytes in them, and also sprouted grains. So you can still eat bread and things like that. There's lots of good sprouted grain breads out there now. But basically, 80-20 rule. Most dietitians will tell you this. 80% of the time, eat clean, so eat those healthy foods, and then 20% of the time, eat and drink whatever you want. We believe in moderation, not deprivation. So if you actually are in having bouts of nausea, so whether it's mild nausea or major nausea, so if it's mild to moderate nausea, try and keep eating. Eat small meals more frequently. So small meals can be just a smoothie or soups. If you're really, really nauseous and vomiting, then stick to broth soups. But if you just have mild, moderate nausea and you can still get something down, try to make sure you're eating soups like chicken noodle soup or chicken soup with rice. You can also try little yogurt cups, cheese and crackers, toast, just plain toast if that's all that feels good in your body. Really, that's what it is. It's about what feels good in your body when you're going through this. Make sure that you stay well hydrated. I mentioned before, you can try Gatorade or Pedialyte. Just take little sips of it though. But make sure, keep trying. So even if you vomit, just wait, half an hour. Try taking a little sip again. Keep trying throughout the day. Stay away from your favorite foods. This is one thing that, so if you're mildly nauseous, it's probably okay. But if you're really in the bouts of nausea and vomiting, stay away from your favorite foods or they will no longer be your favorite foods. This is something that I saw over and over again, especially so when you're in that transplant phase. That nausea post-transplant can be pretty brutal. So that's the time when you probably want to stay away from your favorite foods. Because otherwise you're never going to want to eat them again. Just the sight of it or the smell of it, you may not want to have it again. We don't want to ruin your favorite foods. We want you to have those later. Eat potatoes. Like I mentioned, potatoes are actually quite a comfort food for many people, and you can eat them in many different ways. So baked, roasted, mashed. You can even eat fries. The only thing there is that sometimes the fat in them, the more greasy they are, the more that's going to make you nauseous. So I would stay away from those. Any, like sometimes McDonald's fries actually feel good when you're nauseous, but sometimes it'll actually make it worse because it'll leave a weird film in your mouth, and that's because of the fat. So for that reason, avoid fatty foods like bacon, sausage, things like that when you're nauseous. Because those also, it's going to taste funny in your mouth, and that it's because of the fat. It makes this weird film in your mouth. Make sure you're getting enough protein. Chia seeds, hemp hearts. You probably never thought that those things have lots of protein, but they do. Almonds, pumpkin seeds. I had no idea how much iron is actually in pumpkin seeds, but there's quite a lot. You can add pumpkin seeds to your cookies, to banana bread, to your smoothies. And it's excellent, especially in banana bread. Banana bread, when you're nauseous, is actually a good thing to eat because it's got lots of potassium in it. And then you put in some pumpkin seeds, now you got some iron. Now, if you have nausea with vomiting, then probably avoid that. But if it's just mild nausea, these are things that'll probably feel good in your belly. Everybody's different though, so try the things that you know, and you know your body, so these are just some hints or tips, that's all. And aromatherapy and essential oils, this is another thing that actually some cancer centers actually keep these on hand in the hospital. So things like peppermint and ginger, those are the top two that also can help with nausea. Now it depends, some people, it's one or the other is typically what I've seen, not both. So try one, if that one doesn't do anything, try the other one. Okay. Now I couldn't leave you without talking about dexamethasone. So Tyrannosaurus dex, this is one of my patients coined this term, so I had to use it. I just thought, you can't cry, you gotta laugh, because you know you're gonna have to take it. And this is the thing, dexamethasone is given in combination therapy with pretty much everything you're gonna take, so you're not gonna be able to get away from it, I'm sorry. So we need to learn how to calm this Tyrannosaurus right off the bat. And the sooner we figure out what it's doing to your body and how we can deal with it for you, the better. Some of the side effects include insomnia, high blood pressure, high blood sugar, low blood pressure, all of these things, plus much more. So the best thing to do is learn how your body reacts to it and then figure out the strategies that are going to work for you. So most of the time we tell you to take it early in the morning, but I have had a few patients who actually take it really late at night, so say 9 o'clock, 10 o'clock at night. and then they sleep through most of the symptoms. And when they wake up with that burst of energy. They move on through their day, and then they crash later on in the evening. Make sure you always take it with food. Okay, this is really important because otherwise you're going to end up with a lot of heartburn, and that can make you nauseous. And if you're already nauseated, it's going to make you more nauseated. Make sure you're exercising and doing some meditation. Yoga and Pilates, I just put that because yoga is basically exercise and meditation all in one. Now there's different types of yoga and Pilates that you can do. Some raise your energy up and some raise your energy down. So figure out, try them. Try and see if one of them works better for you. Or even just stretching. You can even just do stretching. Your physio, you can work with them and they can show you some good stretches to do. Plan your days around your dex doses. So if you know you're going to be having a dinner party tonight, make sure take your dex on that day and then relax for 2 days after. Don't try and, take your dex yesterday and then you're doing your dinner party today. Likely that's not going to work out. So make sure that you know your body, you know what dex is doing to you, and just plan for it. You can also try splitting your dose. So I have some patients who actually split their dose over 2 days. More rare to do it over 3 days, but they'll do, say, 20 milligrams today and then 20 milligrams tomorrow. And then they find that the crash, that sort of the up and down, isn't as bad. Just make sure that you talk to your provider first. And of course, we can always dose reduce. So we always try on 40 milligrams first, but we can always dose reduce if that's too much. And as I mentioned before, you can see a counselor, mindfulness therapy, life coach. And also, we do sometimes allow patients to take a drug holiday. Of course, you need to talk to your provider about this. Don't just do it on your own. Make sure, have a plan, and even if it's just, for 1 month while you're going away on a vacation, maybe you're only going to take your dex 1 week out of 2 or something like that. You guys can come up with a plan together. Just make sure that you tell your provider. And other supports, as I mentioned earlier, so Myeloma Canada, they now have there's a plethora of information on their website. There's support groups that I mentioned. They've also got educational pamphlets. You can ask for any of these things. They also have a 24-hour hotline, or maybe it's not quite 24 hours, but I know they have an Ask a Nurse hotline. And some of the provinces have also an Ask a Nurse hotline. Things like 811 in certain provinces. For BC residents, we also have, as I mentioned, Inspire Health. This is a supportive care or integrated care for cancer patients, and it's free. So you just show them your MSP number and it's free. And I know that these are also available across Canada, so just ask your nurse. For sure your nurses are going to know where you can go. Talk to your provider if you really want to consult for physio or kinesiology. Physio and kinesiology, they kind of go hand in hand. At Inspire Health, they actually have physios who also have a kinesiology background. So physios, they tend to focus on rehabbing something that's injured, and then kinesiology is more about training. And so when they have both of those degrees, this is just the perfect combination. Also dietitians, you can see a dietitian if you're having trouble with any of your eating, and then family counseling. So remembering too that your family around you, friends around you, if they also need some counseling, you guys can either all go together or go separately. The International Myeloma Foundation, so I'm actually a part of the Nurse Leadership Board now for the International Myeloma Foundation. So we also have created all kinds of educational webinars similar to what I'm giving today. We've also got lots of pamphlets and information for patients on the website. So I've got the website down there, www.myeloma.org. They have lots of resources. They also do webcasts. You can sign up for those. And we're actually getting ready to, we're just revamping all of our side effect management material, and we're going to be publishing shortly. I think it's coming out in October in Oncology Nursing Journal, one of those journals. So just to summarize, again, the most common side effects we see in myeloma is the peripheral neuropathy, constipation, diarrhea. Rarely we see nausea, but I wanted to mention it. rashes, blood clots, the neutropenia, so low white blood cell counts, thrombocytopenia, which is the low platelet counts, and then anemia and fatigue. But it's important for you to know most of these side effects are manageable, so there's things you can do, even that Tyrannosaurus dex. There are things you can do. You just need to, first of all, work with us, make sure you tell us what's going on so that we can give you some tools, and also just get to know your body and how these drugs are behaving. That's why it's really important to keep a diary of your symptoms, especially if you're on double or triple combo therapy, because sometimes it's really tough to tease out which drug is causing what. So if you keep a diary and we know exactly what days you're getting which drug, and then we can see what side effects are happening after that, we can sort of dial in together and figure out which one's causing what and then what to do about it. So, of course, tell your provider and your nursing team how you're feeling so that we can help you out with that. But really, the things that you can do, the best treatment, and it's going to help with all of your side effects, is taking control of your body. So exercise, good nutrition, plenty of sleep, meditation and mindfulness. So making sure you're getting your mind also to flow well with your body. It's sort of, they go hand in hand. Thoughts become things. I don't know if you've heard this saying before, so it's definitely true. This is another website, tut.com. It's called The Universe Talks. Mike Dooley, he's a little, he's interesting, so he's not for everybody, but I do like this saying of his: whatever I hope to feel in the future, I can decide to feel right now. So really, you know, taking control of your body, your mind, and what you want to see manifest. So thank you very much, you guys, for listening, and I'm going to hand it back over to you, Gabriel.
Thank you, Cindy, for that great talk. Lots of information to digest for everybody online. So I'm waiting for some questions to come in. While I wait for those to come in, for those of you who joined us late, don't worry, this webinar is being recorded or has been recorded, and it will be available on our YouTube site. As I mentioned earlier, you can access that on YouTube if you just search for Myeloma Canada in their search bar, or you can go to our website under the Resources tab and click on Educational Videos, and you'll be able to access those videos. To ask a question on your GoToWebinar panel, there's a questions function. If you type it in there, then I'll be able to read it to Cindy, so you can get an answer. So we'll wait another few seconds for some questions to come in, and if there are no questions, then I wish everybody a happy afternoon and good Saturday. Yeah, so nothing yet. Okay, well, I guess there are no questions. So thanks again, Cindy.
Yeah.
And I hope that we can do this again sometime. It was a really great talk, and thank you again.
Thank you very much.
Right. Have a nice afternoon and evening.
Yes, you guys too. Thanks for listening. Bye.
Bye.